Welcome everyone. Thank you for joining us for today's webinar. My name is Christina and I'm the Administrative Director at Stress and Anxiety Services of New Jersey. Today, Dr. Kennedy will be presenting Therapeutic Termination, Ongoing Goals, and Booster Sessions when utilizing exposure and response prevention for OCD. Dr. Kennedy is a New Jersey and New York licensed psychologist. She is SIPAC certified and can also treat clients in Florida. She specializes in working with children, adolescents, and adults diagnosed with anxiety and mood disorders. She was trained in evidence-based treatment of anxiety disorders and OCD as a postdoc fellow at Stress and Anxiety Services of New Jersey. Dr. Kennedy specializes in CBT interventions for a variety of presenting concerns such as OCD, panic disorder, and BFRBs. She received her BTTI certification in October 2021. Today's presentation is the conclusion of our 11-part ERP training series. If you've purchased the entire package, you will receive a certificate of completion at the end of the series. If at any time you are unable to attend a live session, a video recording and test will be sent to the email you have registered with in order to get your CE certificate. Just a little housekeeping before we begin. Dr. Kennedy will be answering questions during the recorded portion of today's webinar via the chat box. During the last 10 minutes, you will have an opportunity to ask questions live. Any questions she doesn't get to, you can email her with the address provided in the survey that will be sent to you at the conclusion of today's webinar. This survey needs to be completed in order to receive your CE certificate. Certificates will be sent to you by Tuesday of next week. If you do not see your certificate, please check your spam box. And if you still do not see it, please email Christina at stressandanxiety.com. And now we will begin.
All right. Hello, everybody. I am Dr. Jennifer Kennedy from Stress and Anxiety Services of New Jersey. This is part of our OCD webinar series. And so today I'm going to be talking to you specifically about therapeutic termination, ongoing goals and setting goals, as well as the need for booster sessions from time to time with clients, specifically when using exposure and response prevention for obsessive compulsive disorder. So we'll just get started. So you guys know I have no conflicts of interest to disclose for this webinar. To set the mood, holidays are coming up. I just thought this would be cute. I think it's, sometimes putting together all of the ERP sort of bits and pieces can be tough, and this little penguin kind of embodied that. So there will be a lot of Star Wars references and even some Lord of the Rings references thrown in here. Some of the stuff we'll be talking about is really technical, so I wanted to make it interesting. Right. Okay. To start, we'll just go over a little bit, and I want to make this part pretty brief because you guys may have already seen a lot of other webinars from our practice that talked a little bit more about OCD and the ins and outs of OCD. So if you have any questions about this, you can ask me at the end of the webinar, but I'll go through this fairly quickly. So OCD has two main components. And so we have the obsessions and then the compulsions. Obsessions are intrusive, unwanted images, impulses, or thoughts. We commonly think of them as thoughts, but they can also come in the form of images in a person's mind or also an impulse to do something. They're experienced as ego dystonic. And so what that means is that a person does not want this image, impulse, or thought in their head or as part of their body, what they're experiencing. They want it gone. There can be differing levels of how concerned they are about it or how much they agree with the intrusive thought or image or impulse. So some people, especially in the moment, they're like, okay, well, I'm having this intrusive thought about what if something terrible happens to my family? And I'm really thinking that maybe that could happen in that moment. But then afterwards you talk to them about it and they're like, well, I'm thinking about it. I talked to, my significant other about it or my friend about it. And I'm realizing it wasn't really that likely to happen. And in the moment, it still felt really scary. Either way, it's experienced as something that they don't want in their mind, or again, as part of their body with that impulse. Not egosyntonic. So egosyntonic would mean that it's something they very much agree with. They're like, oh no, this is accurate. This is important for me to pay attention to. And I want to be thinking about this. This is a thought that I want in my head, or an image I want in my head. It's something that's enjoyable, or just something that I think is real. So the intrusive kind of thoughts for OCD are ego dystonic. And they often come with anxiety, panic, and fear, but sometimes the feelings can be disgust or even anger or irritability, especially with like the perfectionistic or just right versions of OCD. It can be different kinds of emotions. Either way, it's a big level of discomfort for the person experiencing it. So those are our obsessions. And then our compulsions are what the person does that's meant to neutralize the obsession. So this can be behavioral or mental. And so I think the mental compulsions are really important for us to recognize. The behavioral are very easy for us to see. So we can see somebody washing their hands, or, we can see a student erasing and rewriting. But we can't see somebody necessarily counting or reviewing an event in their head compulsively. We might be able to see that they're distracted, but it's harder to see the mental compulsions. They're just as important for us to assess and just as important for us to know about. So there we have it. We have the obsessions, we have the compulsions, and the compulsions are meant to neutralize the obsessions and help the person with those really big, uncomfortable emotions that they're experiencing. And in doing the compulsion, they reinforce that cycle, strengthen the OCD, and get themselves stuck. So just a little extra on DSM-5 criteria. The obsessions and compulsions for the very specific diagnostic criteria is that they take up more than 1 hour per day, or they cause significant distress that impairs different aspects of a person's life. So it'll impair work for the person, or school if they're a student, or it'll really get in the way of relationships that they're developing with other people. So that's a big part of the OCD, is we need to take into account, how is this impacting the person? It's not explained by another mental disorder. And then we have a couple specifiers. So it's not tick related, or sorry, is it tick related, or do they have good or fair insight or poor insight? And so, like I said before, sometimes people do align themselves a little bit more with the intrusive thoughts. It's harder for them to realize that, okay, this is something that is exaggerated, so they can get there, but especially in the moment when they're experiencing the distress of the intrusive thought, it's difficult for them to realize, all right, this is an intrusive thought. This isn't very likely. So that would be more poor insight. Good insight would be a person who's sitting in front of you saying, I know this makes no sense, and my brain still can't let it go. And I'm still really concerned about this intrusive thought about, what if I'm a pedophile, or I know this doesn't make sense, but, things need to be lined up like this on my desk. Otherwise I can't sit and work. Makes no sense. And I still really need to do it. So that would be more of your good or your fair insight. And then also, making sure that we don't have any other mental health disorders that are responsible for the intrusive thoughts. A lot of our anxiety disorders can have overlap, or even our traumatic kind of spectrum disorders can also have a lot of overlap, as well as different medical conditions. And so we want to really assess, look at all these different factors in a person's life, and then come to the conclusion, okay, we have OCD. All right, so just some quick stats. I think the percent of the population varies a little bit depending on what kind of research you're looking at, but 2% was what I found when I was researching. It can begin in early childhood, and so you do see a lot of children. For me, a very common obsession and compulsion for really young ones, and so people who are like 3, 4 to like 5, 6, or 7, will be a lot of, okay, it's nighttime and I'm going to call mom and dad to me and I'm going to ask for reassurance. Reassurance being a really common compulsion for children. And they might get thoughts, what if something bad happens to my brother or sister, my mom or dad, and I need reassurance that everything is okay. So that'll be a really common obsession and compulsion that's not often recognized as an obsession and compulsion in childhood, as well as different things related to sometimes an emetophobia will start then that'll look a little bit like OCD, or something related to, well, if I eat this food, what if something bad happens? What if I kind of have an allergic reaction? And that can be really relevant for kids because they're seeing that in their classroom. They're seeing people have allergic reactions, or can't bring peanut butter or different things like that. And so these kinds of ideas will kind of get stuck in their head. So that's what it can look like in early childhood. Typically, we see OCD present more in early adolescence to young adulthood, and there's not typically that first symptomatic experience of OCD after age 50. So this is something that does typically start earlier in life. Interestingly, men present sooner than women, so adolescence to early adulthood, but women are more likely to be diagnosed with OCD. Stressors are thought to play a pretty large role in the emergence of OCD. In particular, one of the things we want to look at is after having a baby, and this can be true for men and women, particularly true for women because they're the ones biologically having the baby with a lot of hormonal changes and different things that they're going through. But men as well will experience this in terms of that intrusive thought, like, what if I harm my baby? The intrusive thoughts of harm. And so that can pop up with that huge life change for men as well. And also women having the additional biological component, as well as trauma. There's a lot of connection between OCD and trauma. So somebody will experience a specific traumatic event, and then OCD will kind of grab onto that and start to throw a lot of intrusive thoughts at that person. In addition to, possibly we could have a comorbid PTSD. So into comorbidities. Major depressive disorder is the big one. With major depressive disorder, with the people I see, sometimes I can kind of piece together, is the OCD causing the major depressive disorder? So is the OCD making it difficult for this person to function and, impacting their sleep, impacting their ability to concentrate, their motivation, their ability to maybe just do things that they like to do or spend time with the kind of people that they like to spend time with. And is that then prompting more of the depressive episode, or is the depression something that came first or something that's separate? And a lot of the time I see people who their OCD has gotten so bad and so tough that they start to experience depression. And so we treat the OCD and the depression kind of subsides. It's just that it seems to be even kind of in line with behavioral activation. We're getting them out. We're having them do things that they like to do, and that helps with the depressive symptoms. So sometimes it's good to just kind of assess, all right, what symptoms are more prominent here, and really look at your client and get an idea of what's going on and what do they need first. Do they need to treat this depression first so we could get to OCD, or do we need to treat the OCD first so we can then get to the depression, or maybe the depression won't even be there at that point? A lot of other comorbidities with social anxiety disorder, generalized anxiety disorder, and panic disorder. And this is important to know because the treatments for all three of these are slightly different. And what typically we don't want to do is we don't want to overlap those treatments in a way that makes it harder to treat the OCD. So OCD doesn't typically respond well to challenging cognitive distortions. In fact, that can get a person stuck in that loop of thinking about the obsession more and more, and can actually make them more symptomatic in terms of the OCD. So we want to be careful what kind of interventions we're using for which anxiety disorder. And we also want to really, educate our clients really well so that they understand, okay, I'm not going to use this thought record form to challenge an intrusive OCD thought, which means they have to know the difference between social anxiety and intrusive OCD thought, which can be tough. So lots of psychoeducation, lots of assessment, lots of really knowing OCD and what it looks like, and social anxiety disorder and what it looks like, and panic disorder, because there can be overlap. And generally, exposure therapy for all of these disorders can work fairly well. We just kind of have to know where we want to apply that. We have to know the difference between the symptoms. So comorbidity can definitely make it tough to treat OCD. So we want to be aware of that. Right. Okay. So our evidence-based treatments for OCD, we've got CBT, and that particularly includes exposure and response prevention, which is what we're talking about today. There's also cognitive therapy for OCD, which if you read Wilhelm and Sketty, I likely saying that name wrong. It's a great book, but I don't know if I can say those names correctly. So I apologize. But the book, The Cognitive Therapy for Obsessive Compulsive Disorder, I highly recommend. It's amazing. It gives a good overview of obsessive compulsive disorder, and then certain cases when it might be more beneficial to use cognitive therapy. So I know that's something, depending on who you talk to, they'll be like, no, don't use cognitive therapy for obsessive compulsive disorder. But I think the book does make a good case for certain kinds of OCD, where it might be helpful to use cognitive therapy. And specifically, they talk about a couple of case studies where the OCD is a little bit more cognitive, and challenging beliefs around the OCD was important and was very helpful for the individuals. And I think they combine the different treatment modalities well. So something for guys to look into if you're interested. We also have acceptance and commitment therapy. So recent meta-analysis shows it to be pretty effective. I think it definitely adds a component of values-based interventions, and just really looking at kind of how people experience the world in a different way. And so focusing on just kind of like the moment-to-moment mindfulness skills and also awareness skills in a way that I think adds a lot to CBT. And then inference-based cognitive behavioral therapy is new to me. I haven't learned a ton about it at this point, but there is evidence showing that it has a lot of promise. And so yeah, so it's something to look into. I think it does this in a way where it doesn't feed into any kind of obsessions, but it looks at the connection between our obsessions and maybe the meaning behind them for us. So why we're having specific obsessions. A lot of the time in ERP, you sort of say, okay, well, it doesn't really matter why you're having an obsession. It's an intrusive thought, and it doesn't mean anything about you. And inference-based cognitive behavioral therapy kind of says a little bit more about, all right, well, what's the meaning behind this, and how do we kind of note that thought, but then use our good skills to kind of let it go and sit with it and let it be. And so it's a kind of good new front runner for I think people to pay attention to. So that's another treatment modality that we have. So keeping in mind, there are certain treatment modalities that are not effective or can actually be harmful. So we have talk or supportive therapy or psychodynamic therapy. So these therapies can be great for certain presenting problems. The big issue with them is that if you don't know OCD well, or you haven't recognized it, a therapist using these interventions might say, okay, let's take this intrusive thought and let me reassure you over and over again. And so the client might come to therapy, feel terrible, have this worry, like what if I'm a pedophile? And they go to therapy, and the therapist just walks them through all the reasons why they're not, and why that's not likely, and research, and very well-meaning, very well-meaning therapist. And they feel so much better because here's this therapist that they have a great relationship with and that they trust, and that therapist is telling them, you're an amazing person, you would never do this. And they leave that therapy session feeling amazing. But what's just happened is they've gotten a lot of reassurance. So the OCD gets all that compulsion that it's been looking for. So in that moment, short-term relief feels really good. And then the next day or a few days later, they get hit with a lot more intrusive thoughts. So something happens, and they're just like, oh no, I am a pedophile. And then they're in that cycle again. They're locked into it. So it's important to be really careful about how intrusive thoughts are addressed and handled, because we really want a person to be able to sit with uncertainty and sit with an uncomfortable emotion and learn that, hey, I can have this uncomfortable emotion. I can, I can embrace uncertainty. I don't need to run to somebody and get reassurance. I can just be present with it and be okay with it, and accept it as part of life. I am strong. I am capable. Instead of, let me run to this person, let me get this reassurance, let me feed the OCD. So we want to be really careful about that dynamic, which is one of the reasons why it's tough to use these kinds of interventions for OCD. So this also is similar to accommodations. And so when somebody has OCD, they very naturally want to go to, or some people, not everybody, but some people very naturally want to lean on their family members to help them. So this might be, if somebody has an intrusive thought about responsibility, like, what if I leave the stove on or leave a candle on and I burn down my house? And so they might ask a family member, hey, can you just check the house, check all the candles, check the stove, that kind of heater we have in the corner downstairs, can you check that? Make sure everything is okay. And what that does is that person, that family member, is then accommodating the OCD. So we use that word accommodation, which is how other people in the person's life actually feed into the OCD and make the OCD stronger. What they're trying to do is they're trying to help their family member or their loved one. And it's not actually something that helps. What we want to do is we want to get people to say, look, I understand you're really distressed right now. This is really tough. Your OCD is really bothering you. And I'm not going to do something that I know is going to make your OCD stronger. I know you can get through this. I know you can handle this. And so we want people to interact with them in that way. And so, hence my first Star Wars reference of this webinar: strong people don't put others down, they lift them up. So we want family members to lift up other family members, people struggling with OCD, and be like, hey, you can do this, you got this. Because we really don't want to hurt people in the long run. We want, them to kind of sit with the discomfort in the short term, and then in the long term, feel a lot better, feel a lot stronger. Okay, so this is the first of all the technical stuff that we get into. So if you guys have questions at the end of the webinar, let me know. I've got a lot of notes. So if you remember back to graduate school, we have our ethics code as psychologists. These are all the ethical guidelines that I found, that I had to refresh my memory on, that are related to termination within just any kind of client. So this isn't specific to OCD. This is just for us as psychologists in general. So we have if you remember, our aspirational ethical principles. And so there are 5 of them. And one of them is beneficence. I can't say this word. Yeah, beneficence. I can never say that word. And non-maleficence. And that basically says do no harm. So that kind of medical doctor's equivalent to do no harm. And so that is relevant. Again, that's our aspirational principle. So as psychologists, we want to, aspire to that, but it's not like our specific ethical standard written in very behaviorally specific terms. But that's kind of part of all this. And then we have our code of conduct, which has the actual specific ethical standards. So I'm not sure if I explained that well. So again, if you have questions, let me know. So ethical standard 10.10. And I don't know if you guys have this. This was the book that I got in graduate school. So I don't know if you can see this because I have the background blurred, but this is Decoding the Ethics Code. I highly recommend it. You can literally just flip to flip to that chapter and read it, and it just goes through with examples and explains everything. So it's wonderful. But if you don't want to buy a textbook, I also have other reference points for you. So ethical standard 10.10 gives us our framework for how we can terminate with clients. So some of the big kind of points: if a client doesn't need therapy anymore, if they can't benefit from therapy, or if they're being harmed by therapy, it is our ethical requirement that we then terminate with that client. Or we also have the right, if we feel threatened by the client or someone associated with the client, we can terminate with them in that instance. So those are our specific guidelines for that. We do have, there are pieces of that where we do have a obligation for us to provide referrals. And so we can't just say like, okay, I'm terminating with you, goodbye. We do have to provide that person with referrals. Okay. All right, so part of that referral process and part of the termination process is we really should be thinking about termination during the initial assessment. And so some of this is really being able to walk the client through like, okay, especially with CBT, we don't typically have long-term therapy for CBT. We're just like, hey, I am here to teach you these skills, and then you're going to practice using these skills, and I'm going to give you feedback on that. We're going to work on it. And at a certain point, you're going to be able to apply this yourself because you're strong, because you're capable, and you won't really need me anymore. And so we'll kind of switch out the sessions. We'll maybe meet once a month for a little while. We'll see how you're doing. We'll do any booster sessions if you need it. And then at that point, we would terminate, or with kids, I usually say just graduate from therapy. And if you ever need me, I'm here. You have my contact information. And at that point, we wouldn't be meeting. So you're providing that framework. You're letting the person know from the very beginning, in that initial appointment, this is sort of what I have in mind. This is what this looks like. Because people may not have been in therapy before, or if they were in therapy, it may have been with a therapist from a different treatment modality. So they may have done it a little bit differently, or they may have gone to a big organization where, again, things might be run a little bit differently. And so you want to give people that framework. We also want to take into consideration when we plan going on vacations, or when there's any kind of leave for any reason, and we want to give adequate notice. And so for some of my clients, a couple weeks is fine. For other clients, I would feel like I would need to give them more notice. And so that's kind of up to our clinical judgment. We definitely want to give plenty of notice when leave is planned. And when we do terminate with somebody, we want to make sure that we provide them with referrals, with both verbal and written referrals. So that's another part of this process with us, with clients with termination. And kind of one of the things that they always said in graduate school over and over and over again is, if you didn't document it, it didn't happen. So another thing that I felt the need to include was make sure that you document this. And so if you give illicit referrals, have that somewhere in your notes. And so just listed somewhere, maybe in the termination summary, these were the referrals. Otherwise, you can't really say that you did that. With termination, we want to balance termination with abandonment laws. So abandonment is kind of, as it stands, it's a client is in need, and we terminate with them without giving them access to appropriate referrals. So legally and ethically, we have a responsibility to terminate appropriately. And so what that means is, ethically, we have the ethical standards that I talked about that are in our psychologist's ethics code. But we also have state laws for us to be aware of. And the state laws are complicated, in particular with things like SIPAC. So I printed out the New Jersey state laws for this, and they do have like a couple paragraphs specific to abandonment. They overlap with our ethical code. So there's not a lot of difference between what it says in our ethical code and the New Jersey state laws. The only thing that they kind of added is, if you're part of an organization, you still are ethically and legally responsible for giving that organization adequate notice so that they can get somebody to cover your clients. So it's a subtle difference. But we as psychologists, we want to keep in mind that there's ethically a responsibility, but there's also legally a responsibility. So when we go to take our jurisprudence exams to get licensed in a state, we want to make sure we're taking that really difficult to read legal speech document and we're understanding what it is that we're signing up for. We're understanding, okay, are there any slight differences in, in my ethical code versus my legal code? Because that's important for us is to know both of those things. And again, with SciPac makes it more difficult. I know a lot of people in my practice are have a SciPac license, and a lot of states are now signing on for that. I just looked up the new, they have on their website a map of all the states that are participating in SciPac, and it's blue if they are, and a lot of states are blue. So at this point, a lot of states have jumped on board and are covered by SciPact. But what that means is that if we're seeing somebody in another state, we really, really need to know, okay, what are Colorado's, what are their jurisprudence laws? Because it's probably going to overlap a lot with, with what's in our ethical code, and there might be subtle differences that are important to know. Okay. So some other things that I was researching when I was looking into this is there's a concept of having what's called a professional will. So this is really planning for unexpected things to happen. We all know if we go on vacations, we're going to let our clients know, we're going to set up an email and away message that has, here's who you contact, here's how you can, get help, go to the nearest emergency room if this is an emergency. We're all going to have that in place. But there are also things that happen that we can't predict, and we don't really know what might happen in the situation. So this would be if, in a terrible turn of events, let's say you're a psychologist and you pass away unexpectedly. We don't want to think about it. It's a weird thing to think about and could happen. We want to make sure that there's somebody to cover our clients in the event of that happening. And so you can have a professional will, which is not a legal will, but it's a document that would have all of the information that a person would need. And you kind of assign that to a colleague that you trust. So I would think, especially for people in private practice and maybe they don't work with anybody else, this would be something to really sit down and think about, who would I give this to? Because the alternative might be that information would go to the psychologist's family. And I don't know if anybody in my family would really know how to handle that. How can I expect them to? They're not psychologist. So in that situation, it might be helpful for people to have just this written document with the name of a professional executor. Again, none of this is legal, but it's all listed out, makes it easy, it streamlines the process. And some other things to think about that are a little less catastrophic are things like, what if you close your practice? What if you're going on maternity leave or paternity leave? And what if you're transferring to a new position or a new job or relocating or anything big like that? So what kinds of things could you kind of include in this sort of interruption of therapeutic services? So I was thinking this was a very strange thing that happened to me, but I was going into the office. I think it was even a Saturday, and it was maybe the 15 minutes before the start of my first session. And the first session was telehealth. And I went to go throw away something, I don't remember what it was, in the dumpster outside the practice. So this was during COVID, and no, it wasn't during COVID, it was before COVID. Well, yeah, it was before COVID, but I went to go throw something out in the dumpster. I forget exactly why. And the gate that you kind of open it up to go throw something in the dumpster, it's not, I guess, like the hinges don't work correctly. So when you push it back, it has the tendency to move back to where it was. So I pushed the gate forward, and then I kind of set it down and was like, okay, it's there. I went to go throw something in the dumpster, and then I turned around and the gate had moved. And so it smacked me in the eye. it was very disorienting and I couldn't see straight and I was panicking. So I was in no state to have a session. I think I had like 6 sessions scheduled for that day. So I ended up calling, we have, great people that work with us in our practice, and they canceled all my sessions and I went to urgent care and they ended up being fine. Um, but that, I think that's something that for me, when I was thinking about this, like what happens if something happens to me and I can't step in and make all those phone calls, or, like I really need to be somewhere else and take care of myself. It's something unexpected that we want to make sure we have something in place to protect our clients should that unexpected kind of thing happen. Um, so these were 2 articles that I found. They're called good practice articles and they're amazing. I've never really seen them before. I didn't really know that this existed, this kind of this article through the APA, but these are the links. I think we'll send out these PowerPoints after this webinar, so you guys will have access to it, but I definitely recommend reading them. They're 3 or 4 pages each. They're short, succinct, to the point, but they're about a lot of these important kind of key issues. So I highly recommend reading through them. They'll kind of go into more detail on the things that we talked about here. All right. Okay, so really quickly, I'll go through a little bit on what exposure and response prevention looks like. So also, this is an image that, talking about intrusive images, this wouldn't qualify as OCD because this is a pleasant one for me. If you know, end of Rogue One, start of A New Hope, the Star Wars movies, this is the scary thing that a lot of people are seeing as they are trying to get away from Darth Vader. They see this picture over here of Darth Vader with his lightsaber. So with exposure and response prevention, it's all about leaning into what's scary and approaching what's scary. So you're going after Darth Vader, you're trying to, get past him. So what we really want to do is we really, really want to be able to assess the obsessions thoroughly and well. What kind of specific thoughts is the person having? Are they impulses? Are they, I think I wrote urges, but what I meant to write was intrusive images. So we want to assess how frequent it is that they're having them, what's the intensity. I usually do that on a 0 to 10 scale. And how long is this thought getting stuck in a person's head? Overall, how are they functioning? Are they not sleeping? That's a big thing that I'll see when OCD gets really rough for people, is it'll pop up in the middle of the night and then they won't be able to sleep, or their sleep will be very, very interrupted, or throughout the day, they'll be sitting at work trying to get things done. They won't be able to get things done. They will try to have a conversation with somebody and they're getting all of these intrusive thoughts in their head. You want to assess for avoidance. Avoidance is a big thing that I talk about a lot with clients. What are they avoiding? And this can come up in very, very, very subtle ways. So avoidance can be just not looking at something. It's so subtle and we don't really think about it so much. Or it can be, I'm going to distract myself. So I'm going to take my phone and I'm just going to be on my phone constantly because I don't want these thoughts in my head. I don't want these images in my head. So we really want to look for avoidance, distraction, and then also safety behaviors. Am I going everywhere with another person because I'm afraid I'm going to pass out? What is the person doing to help keep themselves safe? And then accommodation. There's a wonderful scale called the family accommodation scale, which is amazing to give out to families because we want to see like what is the family doing, or how are they participating in the person's rituals or compulsions. And that can be, I've seen that's mostly family, but I've also seen friends jump in and accommodate as well. Another thing I tell people, like a metaphor I like to say, is if I told you to go stand in the corner and do 20 jumping jacks and that would cure your OCD, what would you think about that? And they'd be like, well, that doesn't make any sense. I'm like, yeah, well, you have to understand ERP. You have to understand why I'm telling you to do this before you do it. So really, that psychoeducation, that explanation for why are we doing these things? Why does it work? you need to spend a lot of time with that before you jump into exposure and response prevention. Because if a person doesn't think this is going to make them better, it's really tough to have them, again, face Darth Vader if they don't know why they're doing that. Because nobody wants to face Darth Vader if they don't know why they're doing it. All right. A big thing with ERP is we want to get down to that core fear. So sometimes it seems like, my core fear is that the house is going to burn down, but maybe the house is going to burn down, my cat's going to die, and also it's going to be my fault. Versus if somebody else leaves the stove on, yeah, all those bad things are going to happen, but it's not my fault, so my OCD isn't as concerned with it. So what's the core fear? What are all the pieces of that core fear that we need to keep in mind? Also, what is the emotion? Because what I'll find sometimes is for perfectionistic OCD or just right OCD, sometimes it's more kind of irritation. And then for different kinds of contamination OCD, sometimes it's more disgust. So there's a discomfort. It gets really big, it's really uncomfortable. But for different people at different times, it can look, the emotion can look a little bit different. It's not always anxiety and panic. So we really want to get at the emotion. We don't want, again, if somebody is feeling disgust, we don't necessarily want them to sit with sadness. We want them to move towards the uncomfortable emotion. And that's when we can assess whether or not an exposure is effective. It's always best to practice in session to see how effective an exposure is. So you want to sit with them, you want them to do it. Sometimes you just kind of get at the wrong thing, and you don't realize that until you're experientially doing that in the moment. And also in the moment, it's very helpful to say, okay, well, what were you thinking? What were you feeling? What was going on in your body? What did you want to do? What was the urge? Were you distracting yourself? Was looking away, was that a safety behavior? Do we think? If I leave the room, how much harder would it be? So those kinds of questions, you want to really get at all the pieces of the exposure. That said, I also always go over with clients, I kind of give them little notes. This is what makes a good exposure practice. So if we're in our head, if we're saying, this isn't so bad, this probably won't happen, we're negating the effectiveness of the exposure. If we are, a second later we do the exposure and then we're like, can I go to the bathroom? And then we're washing our hands, we're negating the effectiveness of the exposure. So really having them lean in is the terminology that I use, is we're leaning in, like mentally, behaviorally, emotionally, like our body is literally leaning into it, and we're allowing for that feeling to be present, because that's how we really over time get ourselves to tolerate that feeling more. And so you're really going over what exposures look like before you then send the person home to do the exposure, because you want them to be successful. If they're not successful, especially for those first couple of exposures, it's going to be really tough for you to convince them to do more of this. I also really like if somebody doesn't do their exposure homework, the behavioral chain analysis. So what happened, what went wrong, in a non-judgmental way. So, okay, so we didn't do this. So what happened? Because I want this to be effective for you. So walk me through it. Was it too hard? Did we actually get up to a 10 out of 10 on our distress scale? Was it a time management kind of issue? Are we having trouble with procrastination? Like what's going on here? And DVT actually does a lot with behavioral chain analysis. And so they've got a lot of good worksheets. If you have access to that, might be helpful in sort of looking at, okay, if this person isn't doing their homework and they're not consistently doing their homework, what's going on here? All right. So here's where I really like the really looking at a person's values. There's a DBT worksheet that I've used before. That if you guys are interested, I can find it and I can send it out to you guys. But it's in the sort of DBT kind of manual, I think, for adults. But it goes over values, and I like that because I can use it to help gain some motivation in people who feel unmotivated. As we go over this worksheet, and some of it is, hey, work is really important to me, or relationships are really important to me, but I'm avoiding, I'm not working right now, and I'm avoiding people as much as possible. And so we get that kind of dissonance, and we talk about it like, okay, this is what you want to do. You're saying these are the things that are important to you, and you're not doing any of them. What's going on there? And so we'll see that's where the OCD is really bugging the most. And then so we can kind of go into, well, if that's important to you, let's talk about how to do more of that. Let's talk about how to throw you back into your life and push back against the OCD. So yeah, here's, if you guys want to read this, you can. But here's another example of how to use people. I just have this little bit about, hey, let's go to a Star Wars movie because that's what you want to do, and you'll have to touch doorknobs. That's okay too. I say with a lot of my clients, I'm like, yeah, you had to do that tough thing. That's awesome. And they're just like, I knew you'd be happy about that. But that's, that's how they make progress. That's how they grow, is those opportunities to do difficult things. But I like that, especially when it's paired with something that they really want to do, something that's been taken from them because of the OCD. And I think that's where you get the most motivation. All right. Also, some other notes about goals is, especially when you're working with children, you really want to be very behaviorally specific. You don't want to be vague about what you're having them do. It's best to practice it in session. But if you can't, like, I'll always just write it out very specifically. I'll either just like write it out and hand it to them, or, sometimes like email it to them, just a very specific kind of notes from, this is what you're going to do. You want it to be very clear, very easy to measure. So you're doing this for 1 minute, not just do it for a little while. You also want it to be very manageable in terms of their anxiety level. So you don't want to, throw them into something that's really tough and they're just not going to want to do it. I love the gym metaphor. It's probably really commonly used, but you don't want it to be so tough that you get hurt. You don't want it to be so easy that you're not making any progress. And so some notes for that. And then also a lot of reinforcement and praise when they do accomplish their goals. This is really important too, because it does get into, thoughts that they might have that might be sabotaging them. Like, all right, well, it's easy for other people to touch doorknobs, so I don't know why you're praising me for being able to do this. And then you kind of challenging that and being like, well, other people don't have OCD in their head, making it really tough. So yeah, it's easy for them. This was really tough for you. And you didn't choose to have OCD in your head making this hard. It just is. And so we need to celebrate this. This was big. So challenging a lot of those thoughts that they have and really getting them to see, this is an accomplishment. I'm proud of you. You should be proud of yourself. It really helps with a lot of the positive emotion and kind of just that motivation to move forward. So again, metaphors are really great. You have the climbing the ladder metaphor, or for kids, face fears. Over here, it's up and down the worry hill. So I've seen this before, and this is something that I think kids like a lot, because especially it gives them the imagery for what they're doing and makes it a little bit more fun. So anything that really speaks to you, metaphor that speaks to the person, it can tap into something that they really like. Those kind of things can be super helpful. Again, any metaphor that I can use that has to do with Star Wars is going to be helpful to me, but I have to keep in mind that's not everybody's thing. So I have to make it very specific to the individual. Some people really love worksheets and hierarchies, and they can be amazing in terms of, you can see the things that you've accomplished and you can write like, okay, we did this and now you're here, or we did that and now you're here. This is way easier for you. And it helps keep you on track, because with therapy, we'd love for it to be a very streamlined process, but what typically happens is things pop up and things change and then we need to reset. And so having that kind of the worksheets for them to sort of work through and be able to reference and look back on can be helpful. It also keeps you organized as the therapist. All right. Okay, so here's our Lord of the Rings reference. So it's time to graduate from therapy. Be tough. And one more thing. Okay. So cognitive therapy and termination specifically. Again, I think I already said this, but it begins the first session. The goal is, you shouldn't need me anymore, and I'm always here for you. Termination is one of those things that brings up a lot for the therapist and the client. And I know that it has brought up a lot for me in the past. Um, it's just it's sad, like we as therapists, we develop a relationship with people and we see them grow a lot of the time, and it's always kind of like a little bit of a loss for us to let them go, and that's the healthiest thing for them. That's part of the relationship. That's part of the ethical considerations and our professional boundaries. I find this to be very difficult with kids. Uh, it's always a little bit harder. Um, so different things come up. Like we have to be aware of our client and the experiences they've gone through in life and how they've processed losses or abandonments. Different kinds of mental health disorders come into play as well. Or just, like different stages of life. Uh, Ultimately, as hard as this is for us and for them, it is a good way to practice therapeutically saying goodbye, expressing emotions. How often do we have the opportunity to express big and complicated emotions in a very safe way? That's something that doesn't always happen. And, like kids, when they transition from one grade to another, they don't always have that kind of safe place to say, oh, I'm going to miss you to their teacher. But, they do have that here. So terminations can bring up a lot of emotions. I think it's important for us as therapists to take care of ourselves, to realize that, we are going to be feeling this too. And then also to give that space to our clients to express whatever it is that they're feeling. They could be mad. They could think that, hey, I want more sessions and you're telling me that we don't need any more sessions. And, that can be a conflict. And for us to really just put that out there, validate how they're feeling, validate that emotion. And then move forward with setting our boundary and doing what we have to do professionally. And having that be a positive experience for the client. I also think that with complicated terminations, it's even more uncomfortable for us. So again, back to, doing what we have to do professionally and setting our ethical boundary or our professional boundaries and following our ethical code is important, and also taking care of ourselves. All right. So for OCD, very specifically, OCD does tend to get more difficult, get bigger around stressful life events. So pregnancy, having a baby, this is really big, that postpartum OCD. But also job changes are a big one, any kind of loss, any kind of relocation, those types of things will kind of trigger more OCD in a person that's vulnerable to it. Another thing is that OCD does change topics or change themes. So somebody who's previously had contamination OCD might start to have, intrusive thoughts of harm. And that might feel very different to them. They might not recognize it right away as OCD. And so one of the things that it's important to go over in like termination sessions and also in just the general psychoeducation around OCD is there are a bunch of different topics that OCD can grab. And here's how it sounds. Here's how it feels. These are the things to look out for and to make sure that our clients have a lot of good resources to read up on it. And so I always recommend different like books, different workbooks that go into different kinds of intrusive thoughts, and also the International OCD Foundation website, because that has a lot of great psychoeducation resources on it as well, and videos and whatnot. Because this way, if that does pop up, they can research that themselves, not somewhere on Reddit where you're not going to get accurate information, but somewhere where you will get accurate information. Right. So we're teaching them to be their own therapist, essentially. All right. Things to keep in mind for those termination sessions are we really want them to be able to pinpoint, okay, how did you know your OCD was getting worse? What did you first notice? What kind of stressful life events are coming up in your life? Are you getting married? Is that going to put you in a place where you have to have tons of fights with your mom and set lots of boundaries with everybody in your family? What's coming up? What might be stressful for you? How can you anticipate that or see what that would first look like? Any kind of changes in your physical health, because we do really know that things like sleep and eating and appetite are all wrapped up in OCD. And so did you notice that you weren't eating? Did you notice that you had no energy? Did you notice your sleep was impaired? What kind of things did you notice that started to kind of kickstart the OCD? What were your emotional triggers? Again, were you really stressed at work and constantly irritable and sad? What was going on? And the behavioral indicators. So what are the first behaviors? What are the first compulsions you started to notice? So really go through that, so you know all of the pieces of this for that person. So if this does start to happen for them, they can identify it early and come in for some booster sessions early, so that they're not really struggling later on. Okay. So we want to be specific too about when a client should reach back out. So these are some things that I've come up with some people, a lot of like crying spells, increases in depression or suicidal thoughts. Intrusive thoughts are making it hard to focus. So they're at work and they're finding it really difficult to get through the day. Their relationships are being affected. So they just aren't communicating with friends or family members. They're not responding to texts or phone calls. Family members, friends, significant others directly say, "Hey, I'm concerned about you." Compulsions are taking up quite some time, so over an hour a day, or they're not sleeping. So these are some frequent things that I would say, all right, if this starts to happen, I want you to reach back out. A lapse versus a relapse too. So you can use the car veering off the road metaphor. So did we just kind of veer a little bit off the road and we can get back on quickly, or did we, tumble down the mountain and it's going to take a lot for us to get back? And so really kind of normalizing the lapse and saying, okay, how, when we have a lapse, do we get back on track? Another tool that I like to use is this is actually from Psychology Tools. But it, for me, normalizes intrusive thoughts, because what I think a lot of people don't recognize, and one of the sort of big psychoeducation points that I have with people is intrusive thoughts are common and they're normal in a healthy brain. And that is kind of mind-blowing for a lot of people. So this is from Psychology Tools, and what it did is it looked at a lot of college students and it said, okay, what percentage of men and women have had these kinds of intrusive thoughts? And so you can read the intrusive thoughts. They're all like intrusive, violent, or sexual, or odd kinds of thoughts. And there's a high percentage of people that you wouldn't expect that have had these kinds of thoughts. And so what it does is it normalizes it. And one of the things I'll say is, I remember having like an intrusive thought when I first started driving, where the intrusive thought was, what if you veer your car off this bridge into the water? And I remember, I think I was like 16. I had just gotten my permit. And I was like, oh, wow, why did you have that thought? That is a wild thought. And it was an intrusive thought that healthy brains have. And so to give people context, your brain will always have intrusive thoughts. This will always happen because healthy brains have intrusive thoughts. And it's about how we handle it. And it's about how we sit with uncertainty, how we tolerate distress and discomfort, and the tools that we use moving forward. So expect this to happen, and have faith in yourself that you have these tools to handle it. All right, and again, I had to have another Star Wars meme, so sorry about that, but let them know they can come back at any time and they have graduated. So we've got a little picture of Grogu in a graduation cap, which is just adorable. All right, so booster sessions. I've talked about this a lot, so I'm not going to go over this again, but you want to make sure you review typical triggers with the person. And you want to also reinforce, like, hey, you have learned these great skills. You are never going to go back to pre-knowing these skills. You've got something you didn't have before. So you really want to reinforce that they've made progress, and that, yes, it could happen again where they would need a booster session, where they would have a lapse or even a relapse, and they can handle it moving forward. They have the tools. One of my favorite metaphors for booster sessions is the Wizard of Oz metaphor. So this is the part at the end where, I hope I'm not spoiling this for anybody, but the movie's been out for a very long time. The wizard is this big green blob and looks magical. And Toto, the little dog, goes and grabs the curtain and keeps pulling it back until you see that it's actually just this regular man creating the blob of a wizard. And so I always say with booster sessions, like, is it the same process, different content? So the process, is the OCD process. It's I have an intrusive thought, I have an uncomfortable feeling, I have a compulsive behavior, and that's our cycle. And those are the pieces. It doesn't change. That's how it always is. And it feels very similar depending on the different content, but it's the same process. So the content is, do we have a thought about contamination? Has that thought about contamination changed just enough so that it's bugging you more? Has the OCD shifted just a little bit so it can get you? But is it the same process? Can we identify that process, as nothing that we don't know? Like, again, a man behind a curtain is a man behind a curtain. It's not something magical. It's not something big that we need to pay attention to. It's just a man behind a curtain. So using that metaphor to have them recognize, this process. You've had it happen before plenty of times. You are smarter than it. You can identify it. You know what to do. And that helps to just improve awareness of intrusive thoughts, images, or impulses in the moment when they might be changing, when the OCD might be trying to get somebody. So that's how I talk about like a new theme and recognizing a new theme, or just a slight change to an older thought. Also just really normalizing. You might need a booster session. It's totally okay. I'm here. And then discuss progress not being linear. So I have a picture here. Hold on. Okay, there you go. I love this picture. I don't know who created it. Otherwise, I would love to give them recognition for it. But it's very beautiful, and I like to show people this because I like the part at the bottom. You can never go back to not knowing. And I really like how it normalizes so many things before we really get to this place of feeling like we're recovered. And it's very adorable. All right, so now I have some case examples to go through. Wow, okay. I probably should not have been so wordy. I apologize, but I guess I wanted to be thorough. So this is our case example in Stu. Stu presented to therapy with contamination obsessions, excessive hand washing, and showering that occupied several hours of his day and made it difficult to focus and be appropriately productive at work. So he makes it clear he's only attending therapy because his wife wants him to. And in therapy, we focus on assessment, psychoed, and choose some ERP exercises. After the third session, Stu cancels, and he doesn't respond when you try to reach out to him. You have some strict abandonment policies in your state, and you're concerned about breaking these guidelines. All right. So what do you think? How do you proceed? So things we want to take into consideration, again, be aware of abandonment laws. However, it is our responsibility to reach out and be like, hey, how are you doing? Do you want to make an appointment? So we want to do that. We want to document that. And then if we don't hear back, we really want to provide referrals. So other therapists that Stu could see. All right. And again, we want to document that. We want it to be verbal and written if possible. Again, we can call, don't have to pick up. We could leave a message. We can only do so much, but here we want that to be documented. I also have the good practice article here if we want to read that. All right. Here's another one. This is Kara. Kara's a 12-year-old preteen. She had some perfectionistic, intrusive thoughts. We complete the assessment, and then we sign an ROI to talk to the guidance counselor at school. Also do the family accommodation scale. So we do a lot of great treatment, and Kara gets to the point where she's doing a lot better. Her symptoms at the end of treatment are very infrequent. She graduates, and 2 years pass. Her dad calls you in a panic. He said that OCD is back, and she's struggling in her classes. Do some talking. We figure out that her father doesn't accommodate her OCD, but there's the stress of starting high school, and new teachers are doing a lot of accommodating. So what we do is we spend a few sessions, we review ERP, and symptoms subside again. All right, so what are the most important aspects of termination counseling for Kara and her dad? All right. So again, the psychoeducation being so important here. Accommodation can really feed into the compulsions, which can make OCD a lot tougher to treat. We want to be thinking about things like Kara in college and when she begins a new job. We also want to consider things like, okay, how do we communicate with the school, with guidance counselors, with teachers? Because a lot of this perfectionistic OCD, teachers can get wrapped up in it. Like they can be asked for a lot of reassurance. They can also give extra time for a student to just rewrite over and over again because they recognize the student knows the information, but the student also, uh, might just be struggling with the OCD. So we want to make sure that teachers are aware of this. And when a student goes to a new grade, new school, it might be all new people, and this might pop up again. All right. And so we also just, now that Kara's older, we want to sit down and really go over the psychoeducation with her again. This is what OCD might look like in college. This is what it might look like with a new job. This is what it might look like when you get in a relationship for the first time, and you might actually have intrusive thoughts about the relationship. So we want to really do that psychoed as part of our termination session with Kara. All right. Okay. Now we have John. Okay, 2 more of these, I promise. John is a 45-year-old man. He presented for treatment with contamination obsessions and compulsions. He's been making really steady progress, but now he and his family are moving to another state. You are not licensed to practice there. He's very concerned that he won't have a good relationship with new therapists and he'll lose all his progress. So how do you handle this? So I think this is a tough conversation to have, but explaining the licensing laws to clients, like sometimes they're just like, well, what do you mean you can't practice in New York? And I get it. I understand where they're coming from. They don't have that information. So you want to explain the licensing laws and also set appropriate boundaries. Because I think sometimes people are like, just just ignore the laws. And part of me gets that urge for them to want to do that, but you want to set those very appropriate professional boundaries. I can't do that. I'm so sorry. So you validate feelings, encourage them to express those feelings, hold your professional boundary. You want to plan the termination session, you want to have him know ahead of time, and you want to provide those written and verbal referrals. You also might want him to schedule that appointment well ahead of time so that he has an opportunity to maybe meet with that therapist and get to know that, okay, this therapist is a good therapist too, and I can continue to make progress. Okay. Okay. I think this is our last one. All right. So Blake is a 17-year-old high school senior, had a lot of obsessions related to death. You complete your assessment and have him practice a bunch. He has a much easier time with his symptoms, makes a lot of progress. You then explain to Blake that it's time for a termination session because, hey, you're doing great. This is awesome. This was our goal from the beginning. But Blake is having trouble with that. He's like, hey, I have different things that I want to discuss, relationship with parents, ex-girlfriends. You're like, okay, all right, we'll have a couple sessions about that with coping skills and whatnot. But you also know that Blake's family is struggling to pay for therapy sessions because you're expensive, you're a very specialized therapist. So you're also like, oh man, I want to keep that in mind for this person. So what do you do next? So you want to keep in mind our ethical standard 10.10 and also beneficence and non-maleficence. You don't want to do any harm. So you want to balance that abandonment, and you also want to balance the do no harm. And so this is tricky because you're looking at, hey, this person has a great relationship with you and they want to keep that relationship, but the family is struggling to pay for you. And you know that they could go within their insurance, with somebody who's covered within their insurance, and that they would pay a lot less, and that would be a lot less of a financial burden. So you have to balance these two things, which is tough and does rely on a lot of clinical judgment. And so this is a really tricky one. So you balance it, talk to Blake, talk to his family, and you also want to look at, again, the severity of his symptoms. Right now, his symptoms aren't super severe. They're kind of a lot of stuff that teenagers typically experience. You want to look at your scope of practice. Does he need family therapy because of the things that are going on with his parents? Are you qualified to provide that, or would somebody else be better qualified to provide that? Would psychodynamic or talk therapy work a lot better for the interpersonal concerns? Like, what kind of things are you looking at? What would be best for Blake? So balancing those things, which again, is tough. All right. So here are some resources for you guys. So I have, again, a lot of the things that I looked into when creating this webinar. I have a lot of links for it and just a list of the books that I referenced and used. So take a look. It's all good stuff. Okay. All right, guys, that's it for me and for all the talking that I have to do. So let me know what questions you have.